Friends, welcome to my workplace for hands-on Phaco and SICS training. This is an extremely challenging case. The patient is 86 years old, had several cerebral attacks, is on Tamsulosin for BHP and very shallow anterior chamber. The cataract is quite hard, pupil is small and extremely floppy iris. Lot of challenges in this case. Let us observe the surgery. The surgery took about 15 minutes. It has been edited to about 11 minutes. Please watch the full surgery. By this time, the main incision and a side port has been made. Air bubble has been injected, and now trypan blue dye is applied underneath the air bubble over the anterior capsule. Now see what happens as I inject some adrenaline. The iris tends to come out through the main wound. From the beginning itself, this challenge. This adrenaline didn't help at all. And now, as I try to wash the dye out of the anterior chamber, again the iris tends to prolapse through the main wound. And now I have to inject visco very judiciously. Inject visco in such a way that the iris doesn't prolapse out of the iris doesn't prolapse out through the main wound. And now this is BHEX, pupil expansion device, invented by Dr. Suven Bhattacharjee of Kolkata, India. The device is taken completely into the anterior chamber and the leading flange is tucked under the iris. Now through the main wound itself, I catch hold of another flange and tuck it under the iris. And now there is only one side port. I have to make a side port on the left side. Inject some visco. Take the lance tip knife and make a side port about 2.5 clock hours away from the main wound on the left side. And now through this side port, BHEX forceps 23 gauge is introduced, and at this time we have to use our non-dominant hand, and this flange is tucked under the iris. The patient is constantly moving his head, but we have to manage. Capsulorhexis is done with the help of a Utrata forceps. Size of this rhexis is about 5.25 millimeter. We get a pupil of about 5.5 millimeter in size with BHEX. Hydrodissection is done. Little tap on the nucleus, and now I inject some visco. See, the eyeball is never still. The patient is moving his head constantly. And now with bimanual rotation, the nucleus is free from its capsule. Why bimanual rotation? Bimanual rotation is very jonular friendly. And now the handpiece is introduced, some superficial cortical lens matter is removed, and now watch submarine job. The tip is buried into the substance of the nucleus. It goes through the nucleus for a distance and then the nucleus is chopped. One more chop. Next, along the initial crack, this piece is separated, chopped again to smaller parts. One more chop on the other heminucleus, and this piece is free and it is emulsified. Ultrasonic energy is 80% in continuous mode, flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury from the very beginning. I will reduce the parameters during emulsification of the last piece. The nucleus sclerosis in this case is about grade 4. So we had several challenges in this case: small pupil, floppy iris, hard nucleus, and very shallow anterior chamber. And now the nucleus has been managed, but there is a thick sheet of epinucleus lying over the posterior capsule. It is dangerous to hold the nucleus. What I do is I do some hydro and make it free from the capsule. This epinuclear shell becomes free from the capsule. There is a gap. So what I am going to do is I will introduce some visco through this gap and push the posterior capsule far behind. And now the handpiece goes again. At this time I am in Phaco 3 mode, epinucleus removal mode, where the vacuum is 300, flow rate is 30, and ultrasonic energy is only 30%. See, the eyeball is constantly moving. The patient is not able to keep his head still. This is another challenge. So you have to have very much calm and composed mind and tremendous amount of confidence to manage such cases. SICS is not easy in such cases. So small people and hard nucleus, you won't be able to do a proper size rhexis for nucleus prolapse if you do SICS. You will have to give radial cuts. You will have to use iris hooks. And now the main wound is enlarged to about 3 millimeter because I am going to use a B cartridge. The advantage of B cartridge is the optic of the intraocular lens is not compressed, there is no compression mark, and the lens opens very easily if we use a B cartridge. The lens has been placed in the capsular bag, and now in this case, since this is a floppy iris, what I am going to do is I am going to use a Simcoe cannula to remove visco from the capsular bag, that is from behind the IOL, so that the visco is completely removed. If I remove the B-hex ring, the pupil will be very small and it will be extremely difficult to remove this visco because the iris will tend to prolapse out through the main wound very frequently, and there will be damage to the iris stroma, superiorly. Now again injecting some visco, I untuck the flanges that was behind the iris and gently pull out the V-hex ring. And now is the time to remove visco from the anterior chamber. There is no visco in the capsular bag, it has been removed. Now see, as I try to remove the visco, you can see how floppy the iris is. Yes, the visco is thoroughly removed from the anterior chamber. We have to be very thorough in removing the visco. And now after hydrating the side ports, the antechamber is formed nicely with BSS. The integrity of the wounds are checked, few drops of mux is applied over the ocular surface and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy and great surgical competence.